Hi, everyone. Thank you so much for joining us today on our first MyCares webinars. And just briefly to say that MyCares is the Michigan Cancer and Research on the Environment study, which is a study funded by the National Cancer Institute, as well as the University of Michigan, to explore the impact of environmental injustice on health risk with a particular focus on cancer. The study is open to anyone between the ages of 25 and 44 living in Michigan, and our website is mycares.health. And we welcome anybody to take a look, and we'll be putting some links in the chat as we go that are relevant to today. And then just to say briefly that our next webinar will be on April 13th, Thursday, in about 2 weeks' time, which we'll be talking about microplastics, which have been in the news a lot. And our resident expert, Dr. John Meeker, will be speaking there. So we'll send out that announcement in a couple of days. We invite you to join us. But now for the reason for us to all be here today, we're going to talk about why colon cancer is becoming more common in young people. And we're very lucky to have Dr. Elena Stoffel with us, who's an expert in this area. She is a gastroenterologist, as well as public health researcher. She runs a cancer genetics clinic here at U of M. She's also the assistant director for community outreach and engagement for the Rogel Cancer Center. She's funded by the National Institutes of Health to study racial ethnic disparities in colon cancer development and outcomes, and also has a deep interest in understanding this shift to younger age at onset. So welcome, Dr. Stoffel, and thanks to everybody for joining today.
Thank you very much, Dr. Pierce, and thank you everyone for joining today. My hope is to just give a brief presentation on where the status of our knowledge is on colon cancer in young people, and then hopefully we'll have time for some question and answer sessions. So I'm just gonna go ahead and share my screen. Can you all see this okay?
Yes.
Oh. Let's see. All right, can you see, you see?
I can see it.
Okay, perfect. All right, so.
But do you want to go into full screen? Which...
Yeah, I've been trying to do that. Let's see. Excuse the, technical difficulties here. All right. Oh, sorry about that.
I think it might be, no.
I'm not sure why this interface is not working. All right.
Well, it's fine.
Yeah, okay, we'll just go with it. So this first slide that I'm putting up is basically the American Cancer Society's Cancer Facts and Figures that talks about the leading cancer diagnoses in the United States. And as you can see, colorectal cancer remains the third most common cancer in men and women, behind prostate, breast cancer, and lung cancer. But the good news is that colon cancer is a potentially preventable cancer. And what we have seen is that in the past 2 decades, among individuals over the age of 50, rates of colon cancer incidence in men and women have been decreasing. And we believe that that is largely due to colon cancer screening. The distressing part about this is that colon cancer incidence in people under the age of 50 is actually going up. And really distressingly, it is going up at a rate of approximately 1.5% per year. And the incident rates have doubled for colon cancer among individuals ages 20 to 49, such that 1 in every 10 colon cancers is now diagnosed in somebody under the age of 50. So these are the folks that were told that they're too young to have colon cancer screening. So what's going on here? How do we think about colon cancer? Well, Colon cancer, everybody has a risk of colon cancer. The question is whether an individual's risk is average risk, which would be 3 to 5% over the course of their lifetime, or above average risk. And when we think about colon cancer risk assessment, we consider an individual's age. So that cutoff used to be age 50, but in light of the recent data that I just showed you, the multiple societies have now recommended starting colon cancer screening at age 45. So 45 is the new 50, everyone. And so people over the age of 45 are now considered eligible for average risk colon cancer screening. But the reality is that some people should be screened younger than age 45. And those include individuals who have a family history of colon cancer. So by family history, we mean one or more relatives diagnosed with colon cancer who are first-degree relatives of yours. So that's mother, father, sister, brother. And certainly individuals that have a personal history that puts them at increased risk, such as folks who have had a previous precancerous colon polyp or previous colon cancer, or individuals who have other conditions that increase the risk for colon cancer, like inflammatory bowel disease, so Crohn's disease or ulcerative colitis. So those folks should be screened earlier than age 45. So as Dr. Pierce mentioned, I run the cancer genetics clinical program at University of Michigan Rogel Cancer Center. And I draw family trees because many of the patients that I see come to me reporting that they have a family history of cancer. And so here I demonstrate to you a family tree where women are circles and men are squares. And this individual is 39 years old. She was diagnosed with colon cancer at 33. And interestingly, her mother also had colon cancer at 45, and her mother's father had colon cancer at age 55. So these are the families that should be making red flags, flashing red lights, bells and whistles, that these families really require very special attention because there is so much cancer in this family that makes us think about the possibility of an inherited susceptibility syndrome. And this family was affected with a condition called Lynch syndrome, which is actually one of the most common hereditary cancer syndromes. So this slide is a bit complicated, but I just want to demonstrate that what we've learned about genetic susceptibility to cancer has grown by leaps and bounds over the past 2 decades. The genes here that I've shaded in blue are the typical colon cancer genes that we used to think of as colon cancer genes. The ones in pink are the hereditary breast cancer genes. And what I want to demonstrate to you is that we're actually finding that there's overlap between different genetic syndromes that can actually increase the risk for multiple different cancer types of cancer. Almost everyone has heard about BRCA, hereditary breast ovarian cancer, and 1 out of every 300 people walking around on the street has a mutation in BRCA1 or 2. Similarly, for Lynch syndrome, 1 out of every 300 people walking down the street has a mutation associated with Lynch syndrome that increases the risk of colon cancer from that average risk of 3 to 5% over the course of a person's lifetime to upwards of 60 to 80% over the course of a person's lifetime. And so finding out if you have a genetic susceptibility to cancer is really important because it changes what we do for screening. Now, we know that cancer screening saves lives. And I think if there's a take-home message today, the take-home message is that if we identify someone who's at increased risk for cancer and we actually start screening that person earlier, we can catch many of these cancers before they become a problem and even prevent some of these from developing. And so the picture that you see on the left is a woman getting a mammogram. The picture you see on the right is actually us during a colonoscopy taking off a colon polyp. And we know that by taking off colon polyps before they become cancers, we can actually prevent cancers. So what do we know about how genetics factors in risk for colon cancer in young people? Well, we actually know from some work that we did here at University of Michigan, as well as work that our colleagues at Ohio State did, which is that approximately 1 in every 5 people who's diagnosed with colon cancer under the age of 50 has a genetic susceptibility. So if we could find out this information before these individuals develop their cancer, we could be able to prevent their cancer. Now, the challenge is that that means 4 out of every 5 young people with colon cancer, we can't find a genetic cause. And that's what brings us to the question of what's causing the cancers in these young people that don't have a genetic explanation. So this is a diagram that was presented in a really impactful study done by Dr. Caitlin Murphy that actually looked at the cancer incidence among individuals born in different years. And what we see here is that among individuals who were born after 1960, the incidence rates of colon cancer skyrocket. And this is super important because we're fond of saying that genetics doesn't change over the course of a generation. Genetics takes, multiple generations to have an impact. But there are things that can change over the course of a generation in terms of what we do, what we eat, what we do for our health behaviors, and the environment that we're living in. And this has led to the area of research that is looking into what changed between 1960 and now that may be increasing our rates for colorectal cancer. And so I'm sure that you've seen articles about this in the popular press, as well as in the scientific literature, trying to look at associations between what are we doing in terms of our health behaviors, our diet, our microbiome, what is happening to the food supply, and what's happening to our environment that might explain the increases in cancer risk that have just continued to accelerate over time. And as we see there, fast food comes up again and again as a potential association. The fact that we use a lot more antibiotics now than we did in the 1940s and 50s. The fact that all of us have probably had antibiotics for ear infections and strep throat and acne treatments and all this sort of thing. And the fact that there's a lot of antibiotics in our food supply, in our food chains now, with processes that are by which both poultry and other meats are raised. So when we look internationally, it's interesting because we see that the rates of colon cancer are different depending on where you are in the world. Up at the highest cancer risks for colorectal cancer is Europe, Australia, New Zealand, and the United States and North America. But what you can see is as you go down to less developed nations, like nations in sub-Saharan Africa and in South Central Asia, the rates of colon cancer actually are lower. So that argues that there's something that we're doing in our kind of developed societies that is increasing the rates for colorectal cancer. Now, when we look at the United States, this is a map that basically shows you rates of colon cancer among individuals under the age of 50. And the darker states are the ones with the highest colorectal cancer risk. So as you see, there are very high rates in Louisiana, Mississippi, Alabama. Michigan is pretty up there as well. But then there are lower rates in states like California and Oregon. And I think that this is an important area that we are looking into. And certainly we have a research study that is actually looking at individuals with colon cancer in Louisiana and in the Detroit metro area to try to identify if there are shared common risk factors that might explain some of this pattern. Now, when we talk about increasing rates of colorectal cancer, very commonly this is associated with the increasing prevalence of obesity in our society. But what I'd like to show you is that on the map to the right, which shows us the prevalence of obesity, the maps overlap a little bit, but not completely. So, and all of us who take care of patients with colon cancer can tell you about young people with colon cancer who were, very avid athletes, not obese, vegetarian, and certainly the rise in obesity doesn't explain completely the rise of colon cancer in young people in the United States. We also see that there are disparities with regard to race and ethnicity. And what this curve shows you is actually the incidence rates in different populations. And Black individuals are in purple. The white individuals are in the green unshaded triangles. Asian Pacific Islanders are in the green dark, and the Hispanics are in the orange. And what you can see is that even though Black individuals have the highest rates of colorectal cancer, the rates are actually rising most rapidly among white individuals and Hispanic individuals. So this gives us a lot of food for thought in terms of what could be explaining these trends. Now, to speak a little bit more about racial disparities, we know that colon cancer incidence and mortality are highest in non-Hispanic Black individuals, and the incidence of colorectal cancer under age 50 is twofold higher. And this was what basically came to popular attention with the unfortunate diagnosis of Chadwick Boseman in recent years. But we don't have an explanation for why colon cancer incidence rates are highest in Black people in the United States. It has been supposed that uptake of colon cancer screening may be lower in Black populations, but that doesn't explain why colon cancer incidence should be higher in people who are too young to be screened. So we're certainly in the process of studying tumors diagnosed in young people to see if there are any molecular characteristics that could help explain why these tumors are developing. And I think that this brings us to the idea that, all of us are at risk for developing cancer. We know that cancers in children are uncommon, but they happen. And so what are things that can make cancers happen that could potentially increase our cancer risk? We know that there are associations between changes in our microbiome that may be modified by what we eat or the antibiotics that we're exposed to. We know that there are differences in inflammation due to other possible underlying inflammatory conditions that people have that can increase cancer risk. And certainly we know that changes in diet it might be able to help decrease cancer risk, but certainly screening for cancers and starting screening early enough is probably the best intervention we have at finding things early and catching them early. So where is research in this area going? Well, as I mentioned, my focus is genetics and the biology of cancer. So I think identifying people who have genetic risk factors for cancer is really important. And certainly sharing your family history with your doctors and knowing your family history is really important because that can help us identify people who may be able to benefit from genetic testing. That might lead to recommendations to start colon cancer screening at age 25 instead of 45. We also are talking a lot about what individual factors, what particular health behaviors may be playing a role. And there's also research going on into what is stress doing to our immune systems and our ability to catch cancers early. We also know that there are impacts about the environment. So there are neighborhoods where there are cancer clusters, and certainly MyCares is doing a lot of investigation in that area. And certainly looking at things that may limit access to healthcare and particularly access to cancer screenings that could impact why there might be higher cancer rates in certain populations. As a health system, Michigan Medicine is working very hard to try to improve access to cancer screenings and certainly setting up systems by which we can help providers both within Michigan Medicine as well as in the state of Michigan to identify ways to find people who are at increased risk for cancer and get them screened earlier is one of our top priorities. And so what can we do? You all are on the call today because you're interested in finding out more. And I think that what we can do is to basically make it a done deal that everybody who's age 45 and over should be having a conversation about their colon cancer screening. 45 and older, cancer screening is now covered by insurance for individuals who are age 45 and older. If they're average risk individuals, options include both colonoscopy or a less invasive stool test, which can check for hidden blood. There are also stool tests that test for DNA, for abnormal DNA. And so anyone who has an abnormal stool test needs a colonoscopy. For individuals who are at above average risk, so individuals who have a family history of colon cancer or have any risk factors for colon cancer, colonoscopy is the best test. But I also think that in addition to screening everybody 45 and older, we need to start a conversation among everyone, regardless of age, about their colon cancer risk factors. And so this should be part of routine health maintenance exams for individuals of all ages, certainly talking about any red flag symptoms. So rectal bleeding is one of the most common red flag symptoms. And in most cases, rectal bleeding is not cancer, but in some cases it is, and this needs to be investigated. So certainly individuals who have symptoms should bring it up to their doctors, and doctors should be diligent about assessing those symptoms and following them up to make sure that they get better. In addition, I mentioned family history. So asking about colon cancer diagnoses, about diagnoses of colon polyps in young people, as well as other cancers, because there can be overlap between breast cancers and colon cancers, as well as other cancer types. And certainly, if there are multiple people in the family who have cancers at young ages, or who have similar types of cancer or related cancers, that deserves a conversation, because genetic testing has gotten much less expensive and it's much more widely available. And these conditions that we thought were pretty uncommon are actually relatively common. And then the work that Dr. Pierce and her team are doing to identify some of the mechanisms by which some of these cancers are developing to help guide treatment and prevention. Certainly, there are certain cancers that do better with certain targeted therapies, and finding out what's making these cancers happen can give us clues on how to prevent them. And a lot of the epidemiology studies, like MyCare's, are trying to make those links between what health behaviors or environmental exposures are associated with cancer risk. And that's really, really important. From our end, we're also working very hard to eliminate disparities in healthcare delivery and increasing access to colon cancer screening and genetic evaluation for people who meet those criteria. And, we do a lot of work looking at what can we do better, and looking at factors that determine whether a person receives high quality healthcare. We know that there are differences in the likelihood that an individual will get high quality healthcare based on where they live, their risk factors. There are system constraints, but provider communication is a huge part of this. And so I would urge you that if you have questions about your cancer risk, talk to your doctors about it, and ask what type of cancer screenings are right for you, given your particular personal and family history. So on that note, I wanted to thank you all very much for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Stoffel, for such a great presentation and such important information. We had a few people submit questions ahead of time, so I'll just ask you a couple of those first, and then we'll move on to our live Q&A. So one of the questions that came in ahead of time is, why 45 to start screening? Why not younger? And what do you think about that?
So that was a big debate, because 50 was kind of pulled out of the air back in the 1990s. And it's because when you look at the curves of when do you start to see cancer risk go up, it tended to go up after 50. But what we've seen is over the past decade, that has shifted a little bit, so that when we now compare the cancer incidence at 50, it now matches cancer incidence at age 45 now. So the epidemiologists looked at the trends and they compared the data from 10 years ago to now, and it made sense to shift it to 45. But that's not to say that people who are younger than 45 don't have a cancer risk, because half of the people diagnosed with colon cancer at young age are under 45. It's just particularly important in those groups to identify any possible risk factors and to have those conversations with your doctor ahead of time.
Super interesting. And so there are a few questions both in the live Q&A and that came in about who should get genetic testing, and how do you know if you should get genetic testing?
So that is an excellent question. And just like Dr. Pierce has the MyCare study, my team and I have a study called MIGHT that is actually trying to help people identify individuals who meet criteria for genetic testing. So there are a lot of complicated criteria for genetic testing. Many of them involve cancer diagnoses under the age of 50, for breast cancer under the age of 50, diagnosis of colon cancer under the age of 50, diagnosis of stomach cancer under the age of 50, diagnosis of ovarian cancer at any age, diagnosis of pancreatic cancer at any age. But I also encourage people to say, when you look at your family history, are there more cancers there than you would expect to see by chance? Are there multiple people with the same or related cancer diagnoses? Bring this information to your doctor. And you can say, you know, I have questions about my colon cancer risk. My mother had colon cancer at 60 and her sister had colon cancer at 55. That there might be enough to meet criteria for genetic testing. And in the past, genetic testing used to be terribly expensive, but now it's much more affordable. And believe it or not, you can actually get a clinical grade genetic test, usually paid for completely by insurance, but if insurance won't cover it, it usually costs less than some of those ancestry tests. So it's important to talk to your doctor about your family history, because chances are that genetic testing may be something that could be helpful to you.
Yeah, I mean, what amazing strides in getting those costs down. And, you know, there's a real example of advocacy efforts and underlying evidence supporting that. So that's really amazing. One of our live Q&A questions is, what do you recommend about genetic testing for people who are unable to learn about their family history because of adoption or early deaths, or times where people didn't really talk about health?
So that's an excellent question. And I think it's a discussion that you can have with your doctor, because I know that I've seen patients in the cancer genetics clinic who really want genetic testing because they have no information about their family, and we go ahead and do that. As I said, every insurance plan is different. So there are some plans that will pay for it, but some plans that won't. But if you paid for it out of pocket, it would cost less than some of those ancestry tests that you see advertised on TV.
Perfect. All right. So we also have a couple of questions about diet. And one of them is, when cost is a factor, what choices would you make about affordable food options that are kind of healthier diets, particularly related to colon cancer risk?
So that's an excellent question. And I think some of the work that folks at Harvard with the Nurses' Health Study and with other studies have been able to do is to look at the dietary histories of people who went on to develop colon cancer. And what they're finding is that there seems to be an association between highly processed foods and cancer risk. So we're talking, when we talk about highly processed foods, we mean things that kind of come in a box or things that come in a bag. I think that the trend tends to be that fresh vegetables and fresh fruit and diets that are low in processed red meats. So hot dogs are probably a bad idea. Bacon is probably a bad idea. But trying to stick with things that are less processed is probably a good way to go. And I think that that's one of the many challenges we have, is that processed foods are more easily stored. They're more generally available in convenience stores. But I think that what we're seeing is that there may be something in the way that these foods are processed and the additives in those foods that may increase the risk for cancer. So I would say from a diet perspective, fresh is better if possible, but sticking to minimally processed foods.
Yeah, and I think this is another area of, potential advocacy, is addressing the issue of food deserts and the availability and cost of healthier food, which is something we're certainly doing a lot of thinking about here in the School of Public Health. So another kind of diet-related question is about intermittent fasting, and maybe more broadly other diets, keto, a lot of popular diets out there. And yeah, I don't know if you, obviously you can't comment on all of them, but kind of what are your thoughts about some of the more common ones?
Right. So the answer is we just don't know. I think that I can tell you that I have worked with, I have spoken with investigators who do work in sub-Saharan Africa, who basically say that folks who eat a plant-based diet in sub-Saharan Africa, there's almost no colon cancer in those communities. I don't think we have any data on intermittent fasting or keto diet and risk for colon cancer, but I think the abundance of the evidence is pointing towards the fact that eating a lot of processed foods and fast foods are probably not good for colon cancer risk, and that probably trying to eat kind of fresher, less processed foods would be the way to go. We don't have any data about intermittent fasting or any of the other fad diets.
So another interesting question related also to diet is there any way to get rid of a polyp other than through surgical removal?
So that's a great question. So we know that polyps develop, and the polyps are more common the older an individual gets. But sometimes we see polyps in young people in their 20s who had rectal bleeding and no family history, and we go in and we find a polyp. Removing that polyp can be done with a colonoscopy. So just, I showed you the picture, we lasso it and snare it right off. There are some data to suggest that your immune system might take care of some of these polyps, and that we may never find them because your immune system takes care of them. But to the best of our knowledge, once a polyp develops to a certain point, removing it with colonoscopy, or sometimes if it's too big, that's when surgery is required to remove it. There's a lot of work that's going on that my group is involved in about using certain medications to try to either decrease the development of polyps. The data has been a little mixed there. There have been some data suggesting that aspirin could possibly prevent regrowth of polyps, but there are also some data showing that aspirin has some downsides and some risks. So recently, the U.S. Preventive Services Task Force kind of said, well, you know, I'm not sure we should be doing aspirin, except for groups that are very, very high risk, like individuals with Lynch syndrome. There's also been some studies that have been looking at whether calcium and vitamin D might decrease polyps, and that study gave some mixed results, actually. So as of now, we don't have any magic pill that will get rid of polyps. We don't know for sure how effective our body is at kind of finding these polyps themselves and getting rid of them, which is one of the reasons why colonoscopy with removal of polyps has shown to have a big effect in preventing colon cancers.
Excellent. So I have a couple of questions about whether certain health conditions are risk factors for colon cancer. So one of them is type 2 diabetes. So could you maybe talk about that?
So that's a great question, because again, there seems to be a little bit of signal right now that type 2 diabetes might increase your risk for developing colon cancer or colon polyps. But the signal is not high enough right now to recommend earlier screening for individuals with type 2 diabetes. So right now, that is not considered in terms of the risk stratification. It's just basically age, family history, and whether or not you have had personal history of polyps, or whether you have a history of Crohn's disease or ulcerative colitis. And those are the main ones. But diabetes may ultimately become a factor, but right now the signal is not strong enough to show that the risk is high enough to change recommendations.
Yeah, and so it's actually studies like MyCares that might contribute to that body of knowledge, leading to changes in recommendations for screening age or recommending it for certain populations, because it takes a lot data on a lot of people to really understand if risk is increased in certain populations. So
Absolutely. And I think, for example, if you have a first degree relative, like a father or a sister or a brother or a child with colon cancer or colon polyps, your risk goes from average risk to 2 times higher than average. So we usually say that's a big enough risk that you're going to make a difference. In contrast, if you have Lynch syndrome, your risk is basically 10 times higher than average. The studies that have looked at diabetes have seen that the risk is maybe 1.5 or a little bit lower than that.
So big numbers to really confirm smaller effects that are clinically important, but we just need bigger numbers. So another question about risk factor is about hemorrhoids and whether hemorrhoids are associated with colon cancer risk.
So hemorrhoids are one of the most common causes for rectal bleeding, and almost everyone will have a hemorrhoid at some point in their lives. And hemorrhoids are usually characterized by bleeding that is that happens and that comes and goes and happens and stops. Eventually, it might get better with treatment for the hemorrhoid with hemorrhoid creams and shrink up the hemorrhoids. There is no association between having a hemorrhoid and your risk for colon cancer. But colon cancers can sometimes bleed too. So the problem is if somebody tells you, oh, it's just a hemorrhoid, don't worry about it. You always have to think, how do I know that it's not something else? And so for that reason, there are recommendations that anybody who comes in with rectal bleeding, we should talk about the characteristics of the bleeding. We should try to treat, if we think it's hemorrhoids, we should treat it for hemorrhoids. But if it doesn't get better or it continues, then an endoscopic evaluation, either with a full colonoscopy or a shorter scope to look to make sure that there's nothing else there that's not hemorrhoids that could be bleeding.
Super helpful. And so I think our last set of questions relate to colon cancer screening. And one of them is, what do you see as the challenges to convince people to screen? And sort of related, there are a couple of questions about the stool-based tests and kind of how that fits into colon cancer screening.
Absolutely. So I always like telling the story of about 20 years ago when I was in training. We went into a mammography unit where women were waiting to get their mammograms. And we asked them how many had had colon cancer screening. And fewer than half of the women eligible for colon cancer screening had had colon cancer screening. And the most common reason why they hadn't had it was they said their doctor hadn't talked to them about it. So that is a big fail on the medical community. And I think we've gotten better about that. But I think having conversations about colon cancer screening is a really important part of normalizing this. Everybody should be screened for colon cancer if they're 45 or older, and some people younger than 45 need to be screened earlier. As we talked about, there are multiple different options for screening now, and you all have seen ads on TV now about colon cancer screening with a stool-based test. The stool-based tests, as I mentioned, are okay if your risk for colon cancer is average. So if you don't have any family members with colon cancer, you don't have any colon cancer symptoms, and you're 45 and older, a stool-based test is probably just fine for you. But if you have a family history of colon cancer, or you have any symptoms, or you yourself have had previous precancerous colon polyps, then colonoscopy is the best test.
Excellent. And what about it? Let's say you do have a family history. What's the right age to start screening?
So typically, if you have a family history of colon cancer in a close relative, like a parent or sibling, we recommend starting screening at age 40 or 10 years younger than their cancer diagnosis. So that would mean if your mother had colon cancer at 50, we start you at 40. But if your mother had colon cancer at 45, you need to start colon cancer screening at 35, or maybe even younger than that, depending on if there is a genetic diagnosis in the family. As I mentioned, for Lynch syndrome, which is one of the most common hereditary colon cancer conditions, we start colonoscopies between the ages of 20 and 25. So certainly the ages of diagnosis of the colon cancer in the family are important to determine the age.
Yeah, so pretty individualized, but you can also do that quick calculation yourself if you know the age at which your first degree family member was diagnosed.
And I think the important thing is talk to your doctor and ask your doctor and say, hey, I have a family history. I'm worried about this. When should I be screened? And the good news is that there's been a lot more in both medical education as well as the popular press about screening for colon cancer. So I think doctors are in a better position now to be able to make those individualized recommendations.
And so the another set of questions relates to other symptoms. So indicative of colon cancer. So you've talked about the bleeding, but are there other symptoms like characteristics of a bowel movement or anything else that people could be looking for?
Yeah, we always recommend that people talk to their doctors about changes in bowel habits. So by changes in bowel habits, we typically mean if there are changes in the caliber of the stool, if it gets much, much harder to pass stool, if you've gone from having like regular bowel movements to having a lot of difficulty having bowel movements. Some of these symptoms can be very common and not worrisome, but particular things like, bleeding is the biggest red flag, followed by kind of the changes in caliber. If the stools start to get pencil thin, that should be investigated.
Okay. So I think, but I'll just put a plug in, which Dr. Stoffel has done many times. You should also be getting screened regularly if you are of the right age. So that is, I think, a message that Dr. Stoffel and I believe in. Prevention, prevention, prevention. It's so much better to never get colon cancer than to detect it early. So finding polyps and removing them, therefore reducing your risk of developing colon cancer, super important. And that's what's, to me, amazing about colon cancer screening. Like cervical cancer screening, we can find precancerous lesions and remove them and detect disease early. So to me, it's like the perfect screening test. All right, I'm just scanning the questions, and I just want to point out, we were talking about the stool-based tests, and there was a question about Cologuard, and that is one of the stool-based tests. So I think we've covered that, but if not, please pop your question in the chat. And so we have one kind of broader question, which is whether there are other cancers that have this similar trend toward being diagnosed at a younger age. And I don't know if you can take.
Yeah. So there's some emerging data that that diagnoses of pancreatic cancer are going up in young people as well. Pancreatic cancer, of course, is much less common than colon cancer. And the average person's risk for pancreatic cancer is about 1%, as opposed to colon cancer, which is 3 to 5%. But we're looking to see if there might be a common explanation for why colon and pancreatic cancer are both going up in young people.
Yeah, so a lot of research to be done. Again, we need everybody's help to develop the data. I'm not sure if we were able to find the link, Dr. Stoffel, to the MITE study, or
okay.
Something that you want us to share out.
Yeah, I can absolutely get that to you. I can also I can also offer that if people are interested in hearing more about genetic testing, I could come back and talk to you again.
That would be great. I think it's such an important kind of shift in how we're thinking about cancer prevention, identifying people at higher risk, and with the, really the big, I would say, scientific advocacy efforts to make it less expensive to test, a real game changer. So I think that's a great idea for a future webinar.
Absolutely. I think the name of the game is to talk about your family history of cancer with your doctor, because that starts the conversation. It gets everybody thinking, what can we do differently? What can we recommend differently that may reduce the risks?
Yeah. And so I'll just read this one last question, just to make sure that the specifics are answered. And that is, are there any contraindications to colon cancer screening with annual Hemocult cards? For example, do patients need to change their diet prior to the test? Also, isn't it true that Cologuard sensitivity specificity are the same as a Hemocult card, but Cologuard is just more expensive?
So the Hemocult cards, we don't use those as much anymore because there is a better test that's called a FIT, a fecal immunochemical test. And that test collects stool in a little tube. And the sensitivity for cancer for FIT is upwards of 80% or so. Cologuard uses the FIT plus some stool DNA markers. And they report a sensitivity for cancer of about 92 to 94%. Now, it's important to say that neither the FIT stool test or the Cologuard are very good at detecting colon polyps. So the sensitivity for big colon polyps is somewhere between 40 and 60%. So that's the reason why, if you have if you're at average risk and have no risk factors, no symptoms, either the FIT or the Cologuard test would be appropriate for you. But if you have symptoms or you've had polyps or you have risk factors, that's why colonoscopy is best. And with regard to cost, Cologuard is much more expensive than the annual FITs. Yeah.
Perfect. So a lot of, so would you say, Dr. Stoffel, really that colonoscopy is the best starting point, or you feel, broadly, is it okay to do the FIT or Cologuard stool?
I think the best screening test is the test that you get done. So I think that if you are at average risk, you can pick whether you want the colonoscopy, the FIT test, or the Cologuard. Any test is better than no test. I think that one of the issues we have with colonoscopy is that we don't have capacity to do colonoscopy for every person in the country. And so certainly, if there are symptoms, absolutely a colonoscopy. If there's family history, absolutely a colonoscopy. But if you have no symptoms, no family history, and you're average risk, then a FIT test or a Cologuard is it's actually more, it's easier and more convenient to do than a colonoscopy. But then if the test is positive, then you'll get your colonoscopy.
Yeah, and so that's why if you go look at the U.S. Preventive Services Task Force recommendations for colon cancer screening, it basically says just get screened. And I think we can close there with that message, which is cancer screening. Perfect. Again, thank you everyone for joining, and we will be sending out a message about our next webinar on microplastics, and please feel free to send follow-up questions to the MyCares email address. Thank you. And thank you, Dr. Stoffel, for really enlightening presentation and questions.
Thank you for having me. It was a pleasure.